Well, every diagnostic test changes probability. The real question is whether it changes probability enough to actually alter your clinical decision making. This is why likelihood ratios matter, because they help clinicians decide whether a test meaningfully increases or decreases the odds that disease is truly present. Hey guys, I'm Dr. Busti, your host and faculty on This Is Why. Welcome back to our diagnostic test series, which is part of a larger group of lectures in evidence-based medicine and biostatistics. Now, at This Is Why is my goal to help healthcare professionals transform their medical knowledge from what to why. Because when you know why you do what you do in the proper context of the evidence, it changes the how, and that changes the everyday decisions that we make at the bedside for the patients that we are serving. In this series, we have three different main parts. Remember, part one, just to keep us oriented, is before the study starts. That's our statistical analysis plan, where we define the groups, the type of data, what type of statistical analysis are we going to do. And then there's the data understanding of it after we've completed the study. That's our summary statistics, and we have both descriptive and inferential statistical analysis that we do. And then we're now focused in on the diagnostic test aspect. So those where we're studying a new test and we want to know how it performs, but also when you're reading the paper, how do you know if it's valid? What does it mean compared to the gold standard that we usually should be using in real-world clinical practice? And we're on this topic on likelihood ratios, but you see there's other topics in this overall understanding of diagnostic tests. There's precision, there's accuracy, there's sensitivity, specificity, the development of the ROC curves, positive, negative, predictive values. Some of these topics are related to the test performance, and some are related to how we apply them and guide our decision making, and likelihood ratios is a great example of that last aspect. How do we apply it? So what is a likelihood ratio? Okay, well, it is another method that we use to assess the value of the diagnostic test results. Okay, so remember, there's the diagnostic test performance, and there's what do we do with the results. It is used to assess how good a diagnostic test is, which tests you might choose, and what order you are going to perform them. Okay. Now, with a particular test, it will help you also to consider the odds that a person has the disease. Okay. So that is fundamentally what likelihood ratio is doing. Now, you can apply a likelihood ratio to your individual patient's pretest probability. Now, your pretest probability is your clinical estimate for the patient. That's based on things like your history, the physical exam, all right, the prevalence of similar patients in your setting, and other risk factors. So think of that pretest probability as your clinical gestalt and understanding the prevalence of what's going on where you practice. So the study that you might read about a diagnostic test will have its own likelihood ratio, pretest probability, prevalence considerations, and your setting has its own. Those two may not line up, okay? And that's why you see variations in the way the results sometimes work in our real world. And you'll see that with likelihood ratios. They vary from one study to the next. Now, the studies that we do analysis on a diagnostic test will give you, if they do it right, the likelihood ratio. It's calculated from the sensitivity and specificity. We're going to see that. I'm going to walk you through how to calculate a likelihood ratio. Also, the odds. Okay. I'm also going to help you to understand post-test probability. I'm going to walk you through a real-world example. So we're going to get there. All right. But a good study done well will give you the likelihood ratio, and I'll show you an example of that. But different studies, like I said just a minute ago, will produce different likelihood ratios, and that's because of, at some level, spectrum bias. Okay. It also is influenced by how the test was performed and what is the established gold standard or reference test being used as the comparison? Okay, so this is why likelihood ratio is often clinically useful, sometimes even more so than the predictive values, the positive and negative predictive values. This type of tool, right, metric, can sometimes travel across various settings a little bit better and lets you update your probability, especially your post-test probability. Now, when we start thinking about calculating it, we mentioned the use of the sensitivity specificity, right? But you need to note something. The diagnostic accuracy of a test is indirectly influenced by the prevalence of that disease, okay? Now, a diagnostic test will obviously perform better when it's used in a selected patient population or sample where the prevalence is higher by nature of the selection. And that's where that selection bias and spectrum bias can sometimes come up. And so that's why you're going to see different likelihood ratios for different diagnostic tests, okay? Or sometimes with the same diagnostic test studied in different ways, all right? It has to do with the patient population where it was developed or evolved from. So how is a likelihood ratio then interpreted? So let's consider a clinical perspective on how to interpret and use the likelihood ratio, trying to make it a little bit relevant. Now, I'm going to read this and I'm going to talk about it very slowly, but it's important to recognize those with and without the disease. That's what this is about, right? Because you're trying to do a test and you have a pretest probability, you're going to try to do a test, and you want to know what the post-test probability is going to be, okay? Especially depending on what the result is. So it is the likelihood or the odds that a patient's test result would be expected in a patient with known disease compared to a patient's likelihood and odds of that same result would be expected in a patient without the known disease, okay? Now let's think about it from another perspective. Basically, what is being questioned is this: will doing this test help me as a clinician in making a diagnostic decision? Otherwise, don't do it. You're wasting your time and money and efforts, right? So if my pretest probability for a particular diagnosis is already low, okay, again, that's that prevalence, my concern, my Gestalt, and the prevalence is also low for that, then doing the test is probably not going to help me as a clinician add to my decision, right? It's probably only going to cost extra money, take up time, potentially put the patient at risk, especially if that test is things like invasive or exposure to things like radiation. And so this assumes that moderate to low likelihood ratios, right? That's where that can happen. If it's a large likelihood ratio, then it can really help that post-test probability. And I'm going to show you in the Fagan nomogram what that looks like. I'll show you what happens if you have a likelihood ratio typically over 1, for sure over 10, what it does to your post-test probability. The visual makes this come alive. Now, considering the bedside use, based on what I just said, so having a large likelihood ratio, again, usually that's about 10 or more for sure, that will increase the post-test probability. And you'll see that in the nomogram that I'm going to show you. That patient has a disease that you are suspicious for, and thus doing the test can be helpful. But what happens when it's the LR and likelihood ratio is really small, usually less than 1? Well, that will also help you, but when it's helping you to rule out the presence of a disease, and thus can also be helpful and worth doing. So it just depends on the perspective, okay? Now let's bridge the gap on sensitivity specificity in the context of likelihood ratios. You remember sensitivity is SNOUT, Specificity is spin, ruling in a disease versus ruling out. Think about a test with a very high sensitivity and a test result that comes back negative. That helps to rule out disease, right? That also drives a very low likelihood ratio. It makes it more negative, okay? How about specificity? Again, ruling in disease. So if you have a high specificity, you have low false positives. So when there is a positive, that helps you to rule in a disease. That drives a very high likelihood ratio. And again, the nomogram will help you see that. So how is a likelihood ratio calculated and then starting to be used clinically? Well, this is the math. The reason I spent time talking about sensitivity and specificity is because you see it in the formula that's presented here. Now, I know those of you that are on our podcast channels, you cannot see this, but a positive likelihood ratio is the sensitivity divided by 1 minus the specificity. Okay, that's basically the true positive rate divided by the false positive rate. Those are all the same. A negative likelihood ratio is the false negative rate divided by the true negative rate, or 1 minus the sensitivity divided by the specificity. So it's important to recognize how these things are playing into the calculation. Okay. Let's look at that in the example that we've been using in this series. Okay. Again, it's arbitrary, made up, using these things to help us to calculate numbers. So in our diagnostic sensitivity specificity lecture, we brought this up. When I was talking about precision, reliability, I brought it up as really calculation of accuracy. We were talking about our negative and positive predictive value lecture. We brought up, this is the same table. So we have our 2 by 2 here, okay? And you see down at the bottom, we have our sensitivity of 90%, specificity of 80%, our accuracy is 85%. And again, I walked how to do those previous lectures. Our positive predictive value was 81%. Our negative predictive value is at 89% at a prevalence of 50%. So remember, sensitivity, specificity is not influenced as much by the prevalence, but the predictive values are, okay? So when you go back and you consider the likelihood ratio formula, those true positives divided by the false positive rate, you just get that from your 2 by 2. So you see the math here, it's 0.9 divided by 0.2, that gives us 4.5. And so what does that mean? What is the interpretation of that point, or that 4.5? Well, that's the odds that a patient with a positive result from that test, they have for that disease, they have a 4 times higher chance of having that than of a patient with a negative test result, okay? And so it's a positive LR, okay? Let's look at the negative likelihood ratio. And again, that's the false negative rate divided by the true negative percent or rate. And so again, you get that from your 2 by 2. So it's 0.1 divided by 0.8, you get 0.13. So it's less than 1, right? So the odds that a patient with a negative test result has a disease is 0.13 times that of a patient with a positive result. That's what it means. It's what you do with it, okay? Now, I recognize this visibly doesn't help as much, but again, the nomogram that I'm getting ready to show you is going to help make that come together. So we have our pre-test odds, we have our post-test odds, and we have our post-test probability. And so that is the other formulas that you are going to, you need to, in order to put all this together. And so let's look at the Fagan nomogram, okay? Now, the nomograms here, when they generate an LR, they're basing it on the study's population. And that's why, again, going back to what I said earlier, you'll see different LRs for different studies on a diagnostic test. But in real practice, us in the clinic or in the hospital, you start with your best estimate of the pretest probability. And it might match that of the study if it looks like your patient population, right? But that's where you start. That's the pretest probability down here where this arrow is. Then in the middle, you see that there's a likelihood ratio. And then over on the far right is the post-test probability or change. Okay? So if we zoom in and we look really close at the likelihood ratios, this is looking at each of these levels, what is the change in probability? And so as you go above 1, you see that the percent is increasing, 15, 30, 45% at each of those levels. And going down, again, the difference is by 15% at each level. Okay? So when the LR is greater than 1, the post-test probability is going to likely be higher than the pre-test probability. And I'm again show you the example. If it's less than 1, then it's going to be lower. Okay. So let's look at it. Let's look at an example. So this is an example where the likelihood ratio is greater than 1 and what the nomogram shows us. So if our pretest probability of concern is, let's say 50%, and our likelihood ratio is greater than 1, you don't know, I didn't give you exactly which one it was, so you have to pick the number on this scale. But you can see it went from 50 to now 80% post-test probability. So if that test comes back with a specific result, that is improved, helping me to make that diagnosis. What about if it's less than 1? I started out at 50%. I'm less than 1, and you can see that no matter where I go, I'm going to be less than 50. So I'm not improving it, I'm removing it. So remember, this may help us rule out a disease. Okay? So when the pretest probability is somewhere between 30 and 70%, right, test results with a large likelihood ratio will rule in disease. Okay? A very low likelihood ratio, less than 1, will help you to rule out and the chance of the patient has the disease. So that 30 to 70% right here, 30 to 70%, if you have a large likelihood ratio, especially like at 10, look what it's doing. It's changing it significantly. It's improving my post-test probability. And the same thing would happen with the last one. So let's take a real-world clinical example that I've used in other lectures to continue the conversation about pain over speed bump as an indicator, as a test to help rule in or rule out the concerns for appendicitis. Remember, this is a predominantly rule out thing, a test that we ask about. So in this, the reason I use this is because it's very well done. The sensitivity is 97%, specificity is 30%. We usually see that effect for many tests. You see the positive predictive value is 61%. The negative predictive value is much better at 90%. So remember, it's helping us to rule out disease. But look at the likelihood ratios. So the likelihood ratio of a positive result is 1.4. If it's a negative result, it's 0.1, right? So they give us all of those values. This is well written and very helpful. And so if we apply that to putting it in our own practice, and I have a 28-year-old with right lower abdominal quadrant pain, right? And I have a pretest probability for acute appendicitis that I estimate to be 35%. Okay, then I can now calculate my pretest odds, my post-test odds, my post-test probability. So you can see that my post-test probability did go up a little bit because their likelihood ratio of being positive, right, was greater than 1. So there's a slight intermediate risk. What would I do? It's not slam dunk. I'm still not sure. The only way to prove it is to go through surgery, which is an invasive test, puts patients at risk for complications. So I may pursue imaging like a CT scan or even an ultrasound if I can or I have the capability, or I consult a surgeon to make the final decision, right? And so it doesn't by itself in this scenario rule it out like we would want, okay? Now, what about the patient is absent of pain over the speed bump? So now we're thinking about the negative likelihood. So remember the LR is less than 1. Well, look what our post-test probability did. It went from 35% to 5%. They don't have pain over a speed bump. I can safely let this patient go and not do any workup and consults surgery or put them through a surgery, but give them strict return precautions. Do you see how that worked? One increased my post-test probability when they did have abdominal pain, positive likelihood ratio, and the negative likelihood ratio, if it came back negative, they don't have it, it actually helped me further. And that's what a likelihood ratio is supposed to guide you with, whether or not you do a test. Now, I asked a question in this case about, do you have pain over a speed bump? Okay, that doesn't cost anything to ask the question, but you have to know how to be able to apply it to a patient care scenario. So if it's negative, I use the negative likelihood ratio, which was 0.1. If it was positive, I used the positive likelihood ratio, which was over 1. And it improved my post-test probability. So why does this matter clinically? Well, because a single history question changes your decision. And what maybe is the next action that we do? Do we test? Do we not test? Do we admit them? Do we send them home? And great clinicians don't just order a test to order it. They order tests that are actually going to move that probability enough to change the management in either direction. Okay? So having a large likelihood ratio, i.e. greater than 10, usually increases the post-test probability that the patient has what you are suspicious for if they get a positive result. If they have a small LR and a negative result, that helps us to rule out the presence. And it's worth doing that and asking that question. Okay, guys. Well, I hope that helped to pull some things together as another way of thinking about probability and how you decide in a test. We've talked about cut points and cutoffs by the ROC curve and the AUC. We've talked a little bit about when to use a predictive values like positive and negative predictive values, and then showed you the tool of how to use a likelihood ratio in this decision-making process so that you hopefully land better in a more confident, secured position for the patient. And sometimes we just don't know, and you have to put up boundaries and return precautions, and that's okay. So I hope you found it to be helpful. Please give us a like, post a comment, share some information if you feel like there's something more that you would like to add. That's how we learn. We all benefit from that. And I really appreciate it. My name is Dr. Busti, and I appreciate you being on This Is Why. If you use or need tools like this, or you need a program that helps you walk through it, remember we have playlists and collections on YouTube and over at thisiswhy.health for free, and they're accessible to you. Many times board exams are expecting you to know this kind of stuff and how to interpret it and know what to do with it. So if you're studying for board exams, please share this with your friends, your colleagues. Many board exams cover this content. So these tools can be helpful to you. So thanks so much for joining, and we'll see you next time. Take care. Bye-bye.